गुड मॉर्निंग एवरीवन। वैसे मैंने अपनी जर्नी लगभग 8 बजने में 10 मिनट पे ईस्ट दिल्ली से शुरू की थी, लेकिन शायद दिल्ली वालों को पता चल गया कि मुझे वेदांता आना है और मैं अपने लेक्चर पर पहुंच नहीं पाया। थैंक यू डॉक्टर जितेंद्र फॉर रेस्क्यूइंग मी। सो दिस लेक्चर इज रिगार्डिंग अ neurological problem. I think you might have read during your MBBS, and you are also managing these patients day in and out. So nothing new. We are simply revising. I made it more and more concise and simple to understand. This is a hospital we are working. Yeah, the issue. So this is a case presentation. You can read yourself. The 62-year-old right-handed independently functioning man presents 1 hour after the waking up from the sleep in the morning. Witness sudden onset of speech difficulty, right side in numbness and the weakness, and he had no complaints when he went to sleep yesterday night. He is having a moderate aphasia, facial weakness on the right side, weakness in the right arm, leg, and the decreased sensation to the light touch. Blood pressure when he presented to the 210 by 110. Glucose was 79 and the body temperature was 37.2 degrees Celsius. Medical history, type 2 diabetes, hypertension, well controlled under medication, and provisional diagnosis of suspected acute stroke made and the stroke protocol initiated. This is a very classical presentation. I think we know, all the people who are sitting here, they know and they are managing these patients on a regular basis. So what is a stroke? Basically, stroke, just some information. It's a neurological emergency, worldwide, second leading cause of the death and third leading cause of the disability. And a stroke is not the one thing where the patient is suffering, it is the entire family which suffers. Because it depends on the neurological deficit, patient goes to the assisted, partially assisted life to the fully assisted life. So if you are having one patient in your vicinity, in your home, it is not the patient is suffering, it is the entire family suffers. So it's having a significant negative consequence on the society, as I said, as I mentioned. So what is a stroke? Stroke is anything, an acute brain disorder of vascular origin accompanied by neurological dysfunction that persists for longer than 24 hours. And this is the 24 hour, more than 24 hours is the differentiator between the TIA and the stroke. TIA is having the same presentation, but it do not persist that long and patient have a reversibility and the patient recovers. That's a TIA. That's the difference between stroke and all. So anything persisting more than 24 hours is leading to the stroke by definition. Anything which is less than that is not a stroke, that's a TIA, transient ischemic. What is the classification? Mostly all these patients who have sudden loss of consciousness with neurological involvement, 85% are having a ischemic stroke and only 15% are having a hemorrhagic stroke. Out of the ischemic stroke, the large vessels involvement is the 20%, 25% is the small. Cardioembolic means the left side of the heart, embolic phenomena where your embolus is lying in the left side of the heart and which is throwing the systemic embolus. They are constitute 22%. Cryptogenic 30 and the others are 35% are those areas which is not belonging to this. So 35 is a very large number. Cryptogenic is or the synonym to the idiopathic, where you are not able to find any cause, then it's a cryptogenic or idiopathic. Hemorrhagic 15% divided into an entire cerebral hemorrhage, 8% and the 7% is the subarachnoid hemorrhage. This is the classification of the stroke, ischemic and the hemorrhagic. And this is how it basically looks like on a CT scan. If you do the CT scan, they are almost as a very late presentation we are seeing ischemic infarct, IVH and SAH. Very simple. So in this case, CT was done and you are finding it's saying the hypodensity in the left insular cortex. Now first we have to discuss all the risk factor. I made it deliberately in the coloring, red, green and the yellow. Non-modifiable factors which you cannot change. They are the age, sex, race, ethnicity and hereditary. The factor which you can modify, a lifestyle related, that's hypertension, heart disease, cigarette smoking, diabetes, hypercholesterolemia, carotid artery disease, peripheral artery disease, obesity and physical inactivity. Remember one thing, the last one which you are seeing, the physical activity basically contributing everything on that. Although I am not saying the hypertension can be a familial, you can get it from your parents also. Diabetes you can get if it is a type 1 and all, but rest of other things, you just remember everything is related to your lifestyle. All diseases, most of the spectrum, leave aside the autoimmune, leave aside the other things. Even those autoimmune and your other diseases are also can be modified with the lifestyle changes. So last factor, the physical inactivity is one of the major contributing factor right now. We are seeing that people are having a sudden, a sudden cardiac death or cardiac arrest, and a patient not able to reach to the hospital and die before that. There are a whole lot of other factors are also playing their role. Although the medicine, just drifting from my topic, the vaccination, I'm not basically creating a fear factor. Moderna vaccine, Pfizer vaccine are known to cause a sudden cardiac death, while Covishield is known to for the more thrombotic effect or thrombosis. Although these are the contributing factors which are also contributing into that. We are having a plenty of the example available right now, day to day. Potentially modifiable: alcohol, hyperhomocystinemia, drug abuse, and the sleep habits. Sleep is the one major factor. For a healthy lifestyle, you need to have a three component. You need to have a balanced diet, you have to have an exercise, and the sleep. So if you are taking the balanced diet, doing a fantastic exercise, going to the gym, but you are not sleeping at least for 7 hours, good sleep, you have undone everything. Remember one thing, just focus on that part. 7 hours sleep is a good quality of sleep basically needed to balance that two factors, where you are focusing too much on your physical activity in the gym as well as you are taking the food. So you've undone. Focus on that. That's one of the a leading cause. Common sign and symptoms. Be fast. Very simple. You can read yourself. Balance when the patient is not able to balance. Drooping of the eyes, deviation of the face, weakness of the arms, dysarthria, your patient is not able to speak, or slurring of speech. That's a time where you have to act. Because initial first 3 hours is the most golden hour considered for in case of the ischemic stroke. They are the 3 hours where you can make a change. Every minute you are basically losing. That's leading a significant number of your neurons are getting dysfunctional. So time is basically a break. And the symptoms basically depends on the area of the brain involved. If you are having your speech area involved, definitely you are going to have a slurring of the speech. You are having a cerebral involvement, it's having your involvement of your going to affect your balance. So everything depends on that. Depending on your anatomical involvement, that will be your clinical presentation. How it is going to present that? Symptoms are likely to appear in a combination but may occur alone. Difficult to distinguish between the initially when the patient is having a sudden collapse. You cannot differentiate just by looking at that the patient is having a hemorrhagic or the ischemic stroke. It's simply a patient suddenly becoming unconscious, fell down, having a seizures and having a frothing. So these three clinical presentations are the same for both stroke, hemorrhagic or ischemic. Nausea, vomiting, headache, sudden loss of consciousness are more common in the hemorrhagic part. And kind of a severe headache before the patient suddenly becoming unconscious. That gives you a clue regarding the patient might have had a sudden hemorrhage instead of the stroke. So elicit a history of the trauma, coagulopathy, drug abuse, migraine, and oral contraceptives. They are some of the factors which can give you a very much good clue that this patient might have had a ischemic stroke or had some hemorrhagic. So comprehensive neurological evaluation to be done. What are the goals of the neurological evaluation? Confirm the presence of the stroke symptoms first. And remember one thing, don't do your clinical examination and wasting the patient then and there. Pick the patient and run towards a nearby health facility where you can give the resuscitation to the patient. Stroke mimics, I made it a very large and red. These are the differential diagnoses which can also mimic like a stroke, but they are not the stroke. Establish the neurological baseline, observe improvement or deterioration over time. Establish a stroke severity using the structured neurological examination and the scoring system, NIHH, that stands for National Institute of Health Stroke Scale. And this is the list of the stroke mimics, which they can present in the same way: neurological involvement with the sudden onset, migraine, seizure, space occupying lesion, peripheral vertigo, multiple sclerosis, infection, meningitis, encephalitis, vasculitis, blood dyscrasia, intoxication, toxic metabolic process, hypoglycemia, and hyponatremia. Psychogenic etiology and conversion disorder. Look at this. They have changed the name of the hysteria to the conversion disorder now. So now today onward, now you have to call the conversion disorder, which we are taught in our MBBS regarding the hysteria. And this is a percentage which you will see that the maximum percentage in medical ICU, you will find it's a metabolic cause. Most of the time your patient is not waking up on the ventilator. Sudden patient has loud or altered sensorium. Then you have to find a reason. What is going on? And most of the time you find it is the metabolic causes which is affecting your brain secondarily. So to differentiate between the two, when you are trying to take up the patient from a ventilator not waking up, always rule out the possibility of the NCSC, non-convulsive status epilepticus. So you will find good number of the patients are having the same. And the factors are the metabolic factors, as I mentioned, 37.3% contribute that. Cerebral 16.3 is your space occupying lesion. Next is your primarily the brain involvement constitute only 26.8%. Infectious disorder 8.8, and the others basically falls into 10.8 category. So in medical ICU, if your patient is not waking up, you are doing your and suddenly patient lost consciousness. Always, if you are having the EEG facility available, kindly do that. Look at the pupil. If the pupil are equal size and reactive, it means the brain is secondarily involved. It's not having a primary lesion in the brain. And that's one of the clinical, an examination which gives you a fair idea that when your patient is not, you are planning whether should I take my patient to a CT scan. A patient is not in a position to be taken to that. Then always look at the pupil. Pupil equal size and reactive gives you a fair idea that my brain is intact. So brain is secondarily involved because of some systemic effect. Do that from today onward. This is a diagrammatic representation. This is how basically a stroke looks like in a brain. When the major artery is involved, you are seeing there, or the branch is involved, there is a 3 zone. Central zone is the infarct zone or the core. Yellow which you are seeing is the penumbra, and the third is the oligemia. And if you look at on the right side, there is a one vessel, 10%, less than 10% the blood supply you will find in a core area where the tissue is already dead. You can't do anything. But 8 to 18% up to 20% makes your penumbra, and oligemia up to 6 to 8. So this is the yellow and the green area. Your objective to save this particular area which can be retrieved, and you can minimize the neurological deficit to the patient by timely acting and managing these patients. Pre-hospital management at home or maybe at the site. And this is how you have to start being a bystander. If you have done your ACLS, you have been taught that patients suddenly become unconscious, you have to check the pulse and the respiration. If pulse is there, rhythm is there, it means check the respiration, everything is there, it means the patient is having a neurological involvement. Involve them and just call your nearby hospital or facility, shift the patient, relocate. In emergency, the emergency team will be there, inform them in well in advance the high likely chances that my patient is having a neurological involvement. So you should be ready. High likely this patient is having a stroke. Could be. And then once your patient, and the last you are seeing that rehabilitation. Rehabilitation part is the very important part. Neurological emergency is the worst in a way that it basically suddenly changes the quality of life of the patient. A cardiac patient is fully conscious, can communicate, can do anything. Any disease except the neurological. Once your brain is involved, suddenly your quality of life has gone from 100 to the 0 almost. It may be depending on your neurological deficit, even if you are having a focal lesion, but might be affecting your upper limb or maybe the lower limb. You are able to do your job, but look at the quality of the life before the stroke, how you were, and after the stroke. So that way these are the very, very important. I consider them to be the worst kind of a thing. My personal opinion, I'm not saying that. Every disease is the worst. So 8D of the stroke care has to be followed, and this is the list. You are seeing that it's a detection, dispatch, delivery, door. As I said, first three are post-stroke. If it is a witness stroke, is the golden hour, where you can salvage the good amount of number of the brain, which I said the penumbra and your oligemic zone, and that is basically an objective of neurological resuscitation. For any neurological emergency, whether it's a traumatic brain injury, whether it's your stroke, whether it's anything, it's only basically your management has to be same, and you have to very, very quick. So any area secondary to the traumatic brain injury or to the area or to your stroke or ischemic or the hemorrhagic, you can't do anything for that particular event. But obviously your all actions are going to change the outcome of the patient depending on the timely intervention and the management of the patient. And that's why I'm saying every minute you are losing a good amount of your neurons in the brain. So detection, dispatch, delivery, door, data, decision, drug, and the disposition, this all are a chain, basically 8D says, which basically helps and in the management of the patient, and that also makes the difference in the outcome of the patient and also affects the overall quality of life, not only to the patient but to the entire family. Pre-hospital stroke scales. Several scales exist for the emergency medical services to identify the stroke, but out of the 20 existing, 2 are basically being used. One is your Los Angeles motor scale, second is your Cincinnati pre-hospital stroke severity scale. Moving forward, Los Angeles motor scale, maximum score is the 5, where facial drop, arm drift, grip strength you have to see, and this is the scoring system. Any score 4 and more than 4 is having a sensitivity of 81% and a specificity of 89%. Now coming to the Cincinnati, they also take the 3 parameters: facial drop, arm drift, and the abnormal speech. Even if you find the 1 out of these 3, they say your probability of having the stroke is 72%. Look at these 2 skills, such as simple skills, clinically based. You can do your examination and you can at least target to my patient is a high likely possibility of a stroke. And patient, I say that one should not have these problems. They should fall into a 28% and a 16 or 11% of those segment where they don't have a stroke. I also had this problem on the 9th of one of my family member had this problem, but we were fortunate the patient did not have a stroke. It turned out to be only a severe hyponatremia. That is one of the differential diagnosis of the stroke coming in the mimics. So moving to the emergency now, the patient is taken to the emergency. Pre-hospital assessment was being done. Suspicion was being raised that patient is having a stroke. Taken to the hospital emergency. And how the emergency, what is the goal of the management? First, any patient coming irrespective of the pathology, irrespective of the emergency, your resuscitation is the part 1. And when I am saying the resuscitation, it is the ABC, airway, breathing and the circulation, irrespective of the emergency and whether it's a cardiac, whether it's a neurological, whether it's a traumatic, whether it's any problem. Resuscitation is the first part. So assessment, moment you are suspecting my patient is having a neurological, we already informed the emergency that we are sending one suspected patient of the stroke. So NIHH assessment, severity assessment need to be done. Complete initial evaluation and the assessment regarding imaging, vitals and the lab workup. So when you are suspecting a patient is having a stroke, because time is basically a brain. So you have to be very quick, and we are going to discuss in a subsequent slide how we have to, in a time bound manner, we have to manage these patients. Put on a line, send the labs then and there, check the blood sugar, look at everything, initiate your course. So reperfusion therapy is the mainstay. Reperfusion therapy is the mainstay of the treatment if appropriate, and the clinical decision points are airway management, optimal blood pressure. As I said, in a stroke, for thrombolysis there is a prerequisite of blood pressure has to be less than 185 by 110. That's a prerequisite. If your blood pressure is on the high side, manage that and then you give it if the patient is candidate for the thrombolysis. Now, identify the potential candidates for the reperfusion therapy. Type of reperfusion therapy, whether it's altiplase, intra-arterial or mechanical thrombectomy. So what NIHHS, a few words regarding this part, National Institute of the Health and Stroke Skill. It says that it's a simple tool that can be administered in less than 10 minutes. It's used for systemic quantitative assessment of the stroke-related neurological deficit. It is used to evaluate the document neurological status in acute stroke patients and determine appropriate treatment and assist standardizing communication between healthcare and predictor of the both short and long term outcome of the stroke. So this is one of the and skill which gives you a fair idea regarding the status of the patient, regarding the outcome and the future prediction. It is having 15 items, and the trained observer rates the patient's ability to answer the question and perform the activity without coaching or without making assumptions about the patient can do it. Rating for each item stands from 3 to 5 points. 0 is the normal, and there is an allowance for the untestable items. Score ranging from 0 to 42, that's a 42 is the maximum, and 0 is the minimum, that's for the normal, with higher score indicating greater severity. More is the score, more is the severity. And this is a scoring system of NIHS. 0 is the no stroke, 0 to 4 minor stroke, 5 to 15 moderate, 16 to 20 moderate to severe, 21 to 42 is the severe stroke. And this is a chart which is available. NIHS is on the Google, you can see and you can download, although if you are interested in that. This is a NINDS algorithm for these patients when they are in the emergency, how you have to proceed in a stepwise manner. NINDS stands for National Institute of Neurological Disorder. In initial first 10 minutes, what you have to do? Number 1, identify the signs symptoms of the possible stroke, activate emergency response. In our hospital, there is a stroke code. Once you will announce that stroke code, radiology department, neurology department, all the concerned department get activated, and on priority, CT, MRI always kept on standby. So by the time patient is being wheeled from emergency trials to the radiology department, everything is on a standby. This is how this basically works. So in initial 10 minutes, you have activated the emergency response. Support, as I said, your resuscitation, ABC. If patient is hypoxemic, give oxygen, maintain the airway, maintain the vitals. Establish the time to symptom onset with the history that when patient had this problem. Try to that. And alerts the hospital and check the glucose. Remember one thing, glucose is the very important part. Random blood sugar need to be checked because that's one of the prerequisites if you are planning to give the altiplase to the patient, other than the your blood pressure. Within 10 minutes, you have to do your SS ABC, as I said, add oxygen, IV access, glucose level, neurological screening test you need to do, activate the stroke team, order emergency team scan and the MRI, they are on the standby, and obtain the ECG. This is in the first 10 minutes you need to do. Now coming to the next 25 minutes, what you will do that? Immediate neurological assessment by the stroke team and your designee. Maybe most of the people, I don't know whether you might be managing the emergency as well as the critical ICUs. But in our hospital, most of the hospital, critical care team and the emergency teams are the separate. But for those guys, for your own knowledge and the skill, Not only that you are applying this skill to the patient management, this basically needed for your own, skill for the in a day to day. Maybe in the some of your family members had, some of your neighbor had, where you had, maybe one of the known has had this problem in front of you, and they are asking you how we have to proceed. So by knowing this thing, you can at least help them directly or indirectly. So in 25 minutes, you did everything. You took your blood sugar, you took the blood pressure, established the IV line, patient taken to the CT scan. After doing the CT scan, the objective is to just to differentiate whether it's the ischemic or the hemorrhagic, to rule out the hemorrhage. If there is no hemorrhage, then it's a probable acute ischemic stroke. Consider fibrinolytic therapy and check for the fibrinolytic exclusion criteria, whether this patient fits into that criteria, or there is any contraindication for the antiplase. Then you have to move forward. If patient is having a hemorrhage, no reason, shift the patient to an ICU, manage the patient, and the neurology team is, I think, involved right from the step one while you are assisting the patient. Now, for the first 60 minutes, patient remains the candidate for the fibrinolytic therapy, yes. Now go with give your recombinant tissue plasminogen activator or alteplase, no anticoagulation or antiplatelet treatment for 24 hours. So remember one thing, when you are giving the alteplase, you should not give antiplatelet or anticoagulants in first 24 hours. You have to give it after 24 hours once you will repeat your CT scan. So next step after that, begin the post RTPA stroke pathway. You have done your thrombolysis, and thereafter you have to follow that pathway, monitor the blood pressure, look into your neurological status of the patient, and shift the patient to the stroke unit or to emergency. If patient is not a candidate for the alteplase or thrombolytic therapy, give the aspirin and begin the stroke or hemorrhagic pathway as per the requirement. And this is again, I am saying 0 to 10 you maintain, first 24 hours, 45 minutes CT scan, and within 1 hour you are giving a alteplase. Moving forward, imaging in a suspected stroke. Non-contrast CT scan had the initial investigation of choice for distinguishing acute ischemic stroke and intracerebral hemorrhage. So CT scan is basically taken because it's done very quickly, don't take too much of the time. MRI is not an investigation for the emergency. But nowadays, where you are having a suspicion, you need to repeat your MRI just to see the DWI or flare, images, to decide what should I go with when patient is coming more than 3 hours, or they don't know when the patient had a stroke. So MRI also, and the angiography is the one thing. MR angiography and the CT angiography shows the location of the intracranial arterial occlusion, but they take its time. One has to give a consideration when you are using a dye in any of the critically ill patients. Always do a fluid overloading, or euvolemia need to maintain with the normal saline, because contrast induced nephropathy is definitely a distinct entity. And remember one thing, maybe you have done everything, patient is not doing any problem, AKI patient has developed later. I also witnessed 2 or 3 patients in our ICU in the past couple of years, where they are having the AKI secondary to the CIN, and they land into a CKD. 30% of the AKI converts into the CKD, remember one thing. So it's not something which can be overlooked into your ICU when you are managing these patients. One has to remain very, very cautious. Do no harm to the patient. But down the line, after 1 year, 2 year patient having a kidney involvement, CKD. So if you are giving a dye, take all the precaution for the CIN. CT scan, how it looks like on angiography, there is on image after the dye, you are having the blockage in the artery. Moving early signs of ischemic stroke, how you will basically going to see. And maybe we have incorporated these slides keeping in view your exam, because they can be, sometimes these in OSCEs, they are on a radiological table, they have been kept on that. So hyperdense artery, loss of the insulin ribbon sign, lentiform, a blurring, loss of the gray matter and the white matter differentiation, and the sulcal effacement. Effacement is basically a thinning. God knows why the Britishers are used such difficult words. They can use the sulcal thinning, simple word. Effacement is a thinning, basically, another word. Now, a few words about the aspects of the Alberta Stroke Program early CT score. I made it a colorful just to give you an impression in your memory. Alberta Stroke Program early CT scores, what it says, measure of the early ischemic change on the NCTT head scan, has been used extensively in the acute stroke trials, and it's a prospective validated score that gives point for each 10 middle cerebral artery territory regions that do not show early ischemic changes. This is how it is going to help. An aspect of 6 to 10 select patients with a relative small core infarcts. So it helps you in making a diagnosis of the small arterial and infarcts, which otherwise can be missed on a normal CT scan. So imaging in suspected strokes conduct perfusion imaging using either CT or MRI. Now the question comes to whatever I am teaching you, it depends on the 5 studies. I am going to mention them at the end of my lecture. 5 studies. It's everything which I am just teaching and we are discussing right now. So select the patient for treatment who are outside typical time window. Typical time window means 3 hours has gone. Now patient is coming up to 4.5 hours. So what they say is that if antiplase can be used up to 4.5 hours. With 6 hours, if it is a more than 4 to 5 hours, up to 6 hours, then you go with the endovascular thrombectomy or endovascular your therapy. Means you have taken the catheter to that side, place your small doses of your thrombolytic agents and dissolve that. Beyond 6 hours, it's a mechanical thrombectomy you need to go with. Moving forward. Now coming to the MRI, when your time has gone 4.5 to 6 hours, patient came to your emergency, then how the neurologist has to decide? They have to go with this particular study with the MRI. Diffusion weighted, an image and the flare mismatch. What does it mean? In a above, you are seeing that. In a above, you are seeing that in a DWI there is a white area that's having an involvement of the brain, but on the flare it is not there. There is a mismatch. So this is a candidate for your alteplase therapy. But if you are finding that it's a DW and the flare showing the same thing, it means it's too late to go with the thrombolytic therapy. You got the point? There has to be a mismatch. It means that brain is salvageable right now. So you are using your patients who are coming late, more than 3 hours, 4.5 or 6 hours. How you take the call for the alteplase therapy? Based on this MRI study, and based on that you take a call that should I go with that. In above, if there is a gap between the two, DWI and the flare mismatch, go with that. Although remember one thing, it is a neurologist has to come and take the call. It's not our job of being an intense, but we should be aware of the fact. And we are also, if we know that, we can also move into that direction. At least we can expedite the things for the betterment of the treatment and for the quality of the treatment. So these are the two studies, Dawn, Diffuse, 3 trials, showed the improved outcome after the thrombectomy for the patient selected after a specific period, parameters of the computed tomography of MRI perfusion study from 6 to 24 hours. So now good amount of the studies are coming and papers are coming. They says that you can go up to the 9 hour, up to the 6 to 9 hour, 6 hour, beyond 6 hour you can also use the alteplase. But beyond 6 hour up to 24 hour, whether it's an intravascular alteplase, endovascular thrombectomy you are doing, or you are doing the mechanical thrombectomy, that decision will be taken by the neurologist. Although one should be aware of this fact. So extend alteplase therapy, they says 4.5 to 9 hours you can use depending on your MRI studies, right? Moving forward. Few words regarding alteplase. It's pure pharmacology, not much. Within 3 hours, if a patient is a candidate, these are the inclusion criteria: age more than 18. Blood sugar, as I mentioned, random blood sugar has to be more than 50 before you initiate your thrombolytic therapy. Blood pressure should be less than 185 to 110. No evidence of intracranial hemorrhage, non-vascular lesion, brain tumor, excess, and so on. Now, if it is 3 to 4.5 hour, then exclude anyone who following present before you take the call to use the alteplase. That says if age is more than 18, all patients taking oral anticoagulant are excluded regardless of INR. Baseline NIHSS score more than 25, history of both stroke and the diabetes, imaging evidence of the ischemic damage more than 1/3 of the MCA territory. So these are some of the contraindications, even if the patient is coming into the 3 to 4.5 hour of the duration. These are some of the contraindications where you will not do the intravascular thrombolysis, you will just manage them conservatively. Absolute contraindication and relative contraindication. Should I read or should I skip this slide? I think this is a pure pharmacology, you can read yourself. Now coming to the IV alteplase for the treatment of acute ischemic stroke. The dose is 0.9 milligram, we all know. 10% has to be given immediately within 1 minute and the rest of the 90% has to be given in 1 hour. Maximum 90 milligram you can give irrespective of the weight. Clear? Admit the patient to the ICU, it has to be under the monitoring, and while you are giving the alteplase therapy in the first hour, you found that my patient has neurological deterioration. Stop that, repeat CT, check that whether there is some hemorrhagic conversion or something else is going on. You have to be watchful for their neurological status, watchful for your blood pressure, and watchful for the other complications. And remember one thing, if your patient is fine, you find the patient is conscious, managing, so just avoid placing your rice tube, or you can manage them without placing your Foley's, or if you found that my patient is unconscious by the time I arrive, place that everything well before you start. Check your blood sugar, again I'm repeating, check your BP, it has to be 185 to 110, less than 185 to 110, and then you manage the patient. Patient otherwise eligible for emergency blood pressure management, before, during and after. Patient otherwise eligible for emergency reperfusion therapy except that blood pressure is more than 185 to 110. For example, a patient is a candidate for alteplase therapy fulfilling all the criteria, but blood pressure is on the high side. First you have to control that blood pressure, bring it down to less than 185 to 110, and then you start your alteplase therapy, right? And for that Drug of choice, remember, labetalol is a drug of choice in critical care, used in a obstetrical, used in a neurological, used in anywhere. It's a alpha and beta blocker kind of a thing. Very safe, very high therapeutic index, very safely can be given up to the 300 milligram. So labetalol you can use, nicardipine you can use, clobidipine you can use to control your blood pressure. But that's a first prerequisite to initiate your thrombotic therapy. Management of the BP during and after alteplase therapy to maintain the blood pressure. For example, you started initiate blood pressure has gone up. Again, you have to control it, bring it back. Second part, if your patient systolic blood pressure is more than 180 to 230 and diastolic is more than 1 to 120, labetalol, nicardipine, clobidipine has to be in, but blood pressure has to be controlled. You cannot initiate your alteplase therapy until you are having it. If your blood pressure going up during the therapy, control that. Not able to at least look into that part. So that's a counterproductive and can lead into hemorrhagic manifestations. These are some of the complications. Hemorrhagic conversion. If your neurological deterioration is there, check your CT scan, find out that there is a hemorrhagic deterioration, why my patient has deteriorated. Post-therapy, these some of the practical points. Cryoprecipitate is the one thing which you can use in a patient as a 10 units factor. It provides a factor rate 10 units over 10 to 30 minutes and it peaks in a 1 hour and its onset is 1 hour and peaks in a 12 hour. While if you are not having those patients who said I do not want any blood products, you can use the tranexamic acid in those cases. Hematology, neurological consultation has to be and the supportive treatment need to be given. Angioedema can be occur with the after alteplase therapy or with your patient on ACE inhibitors. But if your patient is having a tongue and the mouth, swelling, you have to be cautious. You need not to maintain the APA, but definitely, if your patient is having upper airway involvement, that's some of the emergency. You need to be very aggressive. Steroid, your diphenhydramine 50 milligram, ranitidine need to be given to those patients, or subcutaneous epinephrine has to be used as per your requirement. That's a angioneurotic or angioedema kind of emergencies when we deal in these patients. Tenecteplase is one of the alternative. Dose is 0.4 milligram per kilogram IV bolus, and it has not been proven to be superior or non-inferior to the alteplase. It means alteplase is that number one. Tenecteplase can be used only in a patient who is having a minor neurological impairment. That's one of another agent you should know exactly. Somebody can ask you in an exam. Coming to the mechanical thrombectomy, when the patient is going more than 6 hours, gone to that window above beyond 9 hours, your flare, DWI flare images are saying still the patient can be serviced. The what they say is mechanical thrombectomy can be performed within 6 hours after the onset of stroke, but this decision will be taken only by the neurologist, not by us. Our job is to manage the patient, stabilize the patient, and involve the concerned specialty as per the requirement. Mechanical thrombectomy entails the passing an intra-arterial catheter, just like your coronary artery, reperfusion. It is the same way they do it. This is how it basically looks like. Same, right? Mechanical thrombectomy within 6 hours of onset. A patient should receive a mechanical thrombectomy with the stent retriever if they meet all the following criteria: modified Rankin score of 0 to 1, causative occlusion of the internal carotid artery or MCS segment 1, A is more than 18, NIHS more than 6 or equal aspect more than 6. Treatment can be initiated within 6 hours. More than 6 hours. Dawn and diffuse study, just remember the name. You can read for your own interest. And they say, one says that more than 6 hours, and that says can go up to 24 hours. Right? How you have to basically, after you have given a treatment, how you are going to assess your patient regarding their neurological status. Look at the modified Rankin score. 0, no symptom. 1, no significant disability. 2, slight disability. 3rd, moderate disability. 4th, moderate and severe disability. Bed bound. And 6th is the dead. You can take the snapshot and you can go through that. Simple, very common already. Other supporting measures: patient should be admitted to the specialized stroke unit, cardiac monitoring, supine position with a neutral head position, maintain euglycemia and normocapnia. That's a normal neuroprotective strategies which applies to entire spectrum of your emergencies, neurological emergency. Leave aside the stroke, whether it's a traumatic brain injury, whether it's a stroke, hemorrhagic, anything. These are some of the standard things which you need to apply for your all neurological patients, which on this slide. Other supporting measures regarding the blood pressure. For example, a patient is not a candidate for your alteplase therapy or anything, but blood pressure is on the high side. Then you have to remember that you have to reduce the blood pressure only by 15% in first 24 hours, and keeping the watch on the organ perfusion, because those organs are now used to or maintaining their perfusion with a very high blood pressure. Clear? A candidate, not candidate for the alteplase therapy as well as for the thrombectomy, but blood pressure is on the high side. Then you need to bring down the blood pressure only 15% in the first 24 hours. Be cautious. Other supportive measures involve your physiotherapy. They will come and see for the dysphagia, intermittent VT prophylaxis. Patients with the last cerebral or cerebellar infarcts are high risk for the brain swelling and the herniation during the first days. Keep a close watch on the neurological assessment of the patient. These patients should be monitored closely and early neurological intervention. Neurosurgeon has to be on the standby. If your patient is showing a deterioration, hemorrhage has gone up, midline shift, compression, ICP has gone up, then definitely. These are the list of those 6 landmark trials on based this lecture was which I taught in the last half an hour. National Institute of Neurological Disorder and Stroke, NINS study, ECAS, European Cooperative Acute Stroke Study 3, Wake Up trial, Extended Altiplase study, Down trial, Diffuse 3 trial. This is a list of the 6 trials I'm just mentioning in one slide. If you wish, you can go through, you can take the snapshot for your own. But this lecture was primarily based on these 6 trials and the studies. And again, just to repeat again, in a first 4 less than 4.5 hour, it's a altiplase therapy IV. 4.5 to 6 hour, it endovascular catheter placement and the altiplase therapy, and beyond that you have to go with the mechanical thrombectomy. Take home message. Treatment for the patient with acute ischemic stroke is guided by the time from the onset of the stroke, the severity of neurological deficit, finding of the neuroimaging. Time of the stroke onset is established as the time that the patient has last known or well known. For example, a patient gone to the sleep, in the morning family has woken up, they are not waking up. So you don't know what was the time of your stroke. That time, this DWI and Freire study is going to give you a fair idea whether this brain is salvageable or not. For person who awake with the stroke, this time will be sometimes before they went to the sleep. You can calculate your timing. Severity of the neurological deficit is measured by the means of NIHSS score. Altiplase, as I mentioned, improves the outcome. Duration less than 4.5 to 6 hours between when you are having a patient endovascular thrombolysis and beyond 6 hour mechanical thrombectomy. You can take the snapshot. This is a particular, if you want to go more detail into that, you can go through this particular guideline. That gives you a fair idea. And thanks for your kind attention. Anything, any query, any question you have, please, you can ask.
Sir, I want to ask regarding the timeline of TIA and the essentiality of the MRI in the thrombolysis for the patient. Like a patient who needs thrombolysis, but we don't have MRI availability. But patient may be in TIA as well. We have ruled out the hemorrhage in the CT scan, but we don't have MRI.
Remember one thing, if your patient is coming, as I mentioned, the clinical difference between the two is if your patient is having a neurological symptom more than 24 hours, then it's a stroke. If it is a less than 24 hours, then it's a TIA. Now for the TIA, you need not to do your thrombolysis, you have to just to work up the patient, find out those high risk factors, ameliorate those factors, make a change in the treatment plan. Coming back to your point, probably what you are trying to say is that when the patient is coming to an area beyond 3 and 4.5 hour, am I saying, and you don't have an MRI, no one is going to give altiplase beyond that until they will see the DW and your Freire studies, because that's a one way, it gives you a fair idea. Should I use that? Because altiplase is a double-edged sword. It is not something is always giving you a benefit, although it's basically make the change in the outcome of the patient. But DWI Freire study is the must and needed nowadays and practiced widely everywhere. Without that, nobody is going to give anything.
But this is not a guideline. Do MRI with thrombolysis.
For a patient where you are clinically you are sure that my patient is having a stroke based on those scores, Cincinnati and I mentioned on that, right? You made it, my patient having a stroke. On CT, you found that and patient is fulfilling all the criteria. CT objective is basically to rule out the hemorrhage only. And while you are everything presentation, although if you are lucky that within that span you are having some of the changes on the CT by the time you receive a patient. But if your patient is having a clinical criteria fulfilling for the stroke and patient is having a CT scan ruling out the hemorrhage, that's a candidate for the altiplase therapy. And remember one thing, always involve the neurologist. I'm sorry, can you repeat? So basically this gives you an idea about the overall status of the patient. It takes 15 criteria, 15 parameters on that to assess the patient about the severity, about the outcome of the patient. So NIHSS score gives you a fair idea, but that goes side by side. But that is the one thing, is not basically a primary thing to decide about that. You need to see my patient is coming to the neurological emergency, stroke within golden period of time, making a diagnosis quick. NIHSS score is going on side by side just to see that whether my patient, what is the severity, because that will come in for the prognostication and the long-term skill. So that's one of the chart with the fixed, kind of a questionnaire where you can see and can find out that this patient, there's a high likely possibility, this will be the outcome of the patient. This is that way it is going to help you. Anything?
Sir, if patient is out of window period, then there is any role of profiling anti-convulsant to a patient.
Sorry?
Role of anti-convulsant.
Anticonvulsant need to be given because it adds into a increase into a CMRO2, cerebral metabolic rate of oxygen. Seizure has to be controlled. That's an emergency and at any cost, irrespective whether it's a primary, whether it's a secondary. Seizure prophylaxis, seizure treatment need to be given if the patient is having a seizure, because if you are not controlling the seizure, it is going to add into your increased cerebral metabolic rate of oxygen, further causing hypoxia.
We have to be for prophylaxis?
No, no. Anti-seizure, that was the practice way back in 70s, 80s when I was doing my MBBS. A patient was coming, no CT scan was available. You need to do the prophylactic. No, only when the patient has having a seizure, then you have to use the anti-seizures. Every drug has its own complication. Thank you very much.
Thank you, sir.